and it's not uncommon, not to focus on a morbid topic, but it's not uncommon for kids who are like 6 and 7 to talk more about death for a period of time because they're just starting to understand the concept.
And they have pets.
And the finality of death. And so sometimes parents will be really concerned. They're talking about death a lot.
And the goldfish die, yeah.
Yeah, and that can be concerning, but it can also be part of normal development. They're starting to understand, this is what death is. That death is final. And
Hi, welcome to the Dr. Gil Show. My guest today is my friend and colleague, Dr. Ben Black. Welcome to the show, Ben.
Thank you so much, Dr. Gil. It's a pleasure to be here.
We've been trying to get together for a long time. You are busy. I am busy. Finally, to have an intersection of our times this evening is really, really special. And I really appreciate you making the time, Ben, to come.
Yeah, it seemed like it was never going to happen. We kept kind of going past each other and trading dates, and it didn't work. But I'm glad it worked today.
You're finally here, Ben. Now, Ben is Director of Medical Services at the Thompson Center here in Columbia, Missouri. You're an Assistant Professor of Pediatrics, and you are the endowed Ron Ashworth Professor of Child Development.
Yes, and I'm an Associate Professor now.
Whoa, that's good for you.
So as of a couple years ago, but the websites never get updated.
Well, good for you. Good for you. And like me, not only are you board certified in a general specialty like pediatrics, but you're also board certified because you did a fellowship in developmental and behavioral pediatrics.
That's correct.
So how long is a residency in pediatrics itself?
Yeah, so the residency in pediatrics is 3 years, and that's after 4 years of med school, as you know, and then the fellowship is another 3 years for the developmental behavioral peds. And then just because I'm a glutton for punishment, I did a fellowship in pediatric clinical pharmacology.
How long was that?
Well, it's supposed to be 2, but I did it in 1, so I kind of combined those fellowships into 4.
Oh, my goodness. Now, is that yet another board certification? Do you have to get boarded for that?
I did not get boarded for that.
Oh.
Yeah.
2 is enough.
2 is enough. Yeah, but my wife she joked to me and said, boy, you could have been a neurosurgeon after all this training.
Right.
I was like, yeah, but I like what I do better.
Yeah. We've had a lot of orthopedic surgeons on here, and that residency is 5 years.
Yeah.
I'm still working on the neurosurgeons. They've always got excuses to.
Yeah.
But that's Anyway, we spend many years.
Yeah.
And you, like almost everyone on this show, is an expert in some really amazing things. So today, Ben, I'd like to talk about childhood development.
Sure.
And I got to tell you, when I was a medical student, I didn't appreciate the importance. For me, and here's the notes I have, the bullet points. For me in medical school, it was just another thing to memorize.
Yeah.
The childhood things here, the Piaget thing, the Erickson things here. It was just something to memorize.
Yeah.
I didn't appreciate how important it is. Until you have kids.
Yeah, that's true.
And now you wonder, gee, is little Johnny going quickly, going slowly? Is this a problem? Is it not? And all of a sudden I said, wait a minute, this is really, really important. I'll give you a real world example that I appreciated. It's a small world, so I'll change the names. Let's just say a person close to me had some children, newborns. And I remember she got home with her kids and was sent a gift. And it was a little cooking dollhouse thing with little cups and saucers and rooms and furniture, this big, fancy, beautiful dollhouse. But these were newborns. So I realized that the person that bought this, I mean, they meant well, bless their heart, right? I'm sure they spent some money on this thing. But they didn't know enough to know. They just saw child toy. These are children. These are, of course, right? But they're not ready for this for 5, 8, 10 years, They don't know what a little cup and saucer is. They just emerged into the world, So having some understanding of what these little humans go through, I think is really, really, really important.
Yeah, it is.
Now, an abnormality, and we will get to, is autism, but I want to plug my own podcast here. Episode 25, we did with one of your colleagues, one of our friends, David Beversdorf, who is an expert on autism. So if someone, one of our listeners, is really interested in delving deeper into autism, episode 25 with him covers that subject. So Ben, what made you want to be a doctor? Did you know when you were developing as a young child or adult that you wanted to be a doctor?
No, interesting. Yeah, was it part of my own developmental trajectory? In some ways, yes. And I think when I first really started considering it was elementary school. I had a teacher, as most of us do. We have teachers who kind of inspire us and push us to think, and think big about our futures and things like that. And I grew up in a really small town, 3,000 people in rural upstate New York, and there were no doctors in my family. I didn't know anybody who went to medical school. I didn't know any doctors personally. But this teacher was like, he just kind of pushed me to consider what I wanted to do with my career and gave me a book on different medical careers. And so I...
When you were a kid? Elementary school?
Elementary school.
Really?
And I think I was late elementary, 5th or 6th grade. And, I remember leafing through it and thinking, I want to be a doctor.
Because you did know early.
Yeah.
I knew when I was 5. Yeah. I was already doing surgery on my stuffed animals. I knew I wanted to be a surgeon.
Yeah, I was not doing developmental testing on anything.
And then what drew you to pediatrics?
Yeah, that was a little bit of a longer road. I think the seeds for that were planted during my undergraduate years. I was at the University of Rochester in upstate New York. And every summer through college, I went and worked at a special camp in upstate New York for kids with severe medical illnesses. It was a double H, Hole in the Woods was the name of the camp, and it's one of the Paul Newman camps. And it was there I was exposed to a lot of kids with complex medical issues, and certainly some kids with neurodevelopmental challenges. And I was just there as a camp counselor, like helping them just have the time of their lives. I mean, we're taking kids with spina bifida, getting them out of their wheelchairs and getting them up on a ropes course, and getting them in the front seat of the roller coaster at the amusement park, and it was just so fun, right?
And rewarding.
Rewarding. It was the best job I've ever had in my life, and I think that's where the seeds were planted. And then when I went on to med school, I was thinking about some different specialties, but ultimately decided on pediatrics, and then didn't know my specialty existed until I was a resident, and I did a required rotation. I'm like, what is this? Behavior and development. I'm like, well, I have to do it. But then once I did it, I was like, this is the patient population I really love. These are the kids that I love working with, the families I love working with. And so the rest is history. It clicked.
The rest is it. That's fantastic. So it almost found you.
Yeah, it did. It definitely did. I wasn't looking for it. I was thinking about some other specialties like physical medicine, rehabilitation, psychiatry, child neurology. None of them really resonated with me like developmental behavioral peds did, though.
Fantastic. And obviously you're very talented. You don't get an endowed chairmanship, an endowed chair, professorship, I should say, without people really liking you and appreciating you. And I know at the Thompson Center, you're a very important part and leader of that team. So we came to talk about childhood development, cognitive development.
Mm-hmm.
Popular culture and something that has dominated this field for decades revolves around Sigmund Freud, a psychiatrist.
Yeah.
And everything always seemed to be revolving around sex and genitals with him.
Yeah.
And maybe it should. I don't know. Maybe he was right. But he thought that the phases of development started with the oral phase, because you have to nurse, you have to suck, right? And then you have to poops, and then there's the anal, and then there's you realize you're peeing out of your genitals. So there's the phallic or the genital. Then there's latency where everything's kind of quiet for a while. And then more of the genital when you go through puberty and you kind of awaken up to these things. And he thought that if you got stuck at any of these, you'd get fixated and you wouldn't make it through it and whatnot. And then they have the Oedipal complex, and then Jung, another psychologist, metaphysicist, talk about the Electra complex, which is kind of like the female version of this. In your opinion, was there ever any real science to support these phases, or were these more musing and theories that Freud came up with?
Yeah. A lot of the theories of development are more the latter. They're kind of musings and theories, certainly based in some level of reality, like any theory. There's some basis for it, but I think the way we think about development now is kind of across a variety of theories. There's Piaget and Erikson and others, and some of those theories we think about a bit collectively now, and really focused on developmental milestones and each child kind of following their own trajectory. And sometimes it's helpful to think about childhood development a little bit like we look at growth curves, right? There's the 5th percentile, the 95th percentile, and sometimes we get stuck on childhood development has to follow this very linear course because that's how it's labeled in the textbooks. You do this at 6 months, and this at 9 months, and this at 12 months. And yes, you want to see those things develop along a certain time period and course, but there are some children who are going to go through those developmental phases more quickly and maybe be, in that 95th percentile. They're getting through things more quickly. Some that are going to go through it more slowly. And in either case, there may be areas where the child needs some support in order to encourage positive development. And things are not always so smooth. Sometimes kids, what we see with child development is that often kids might be focused in on some area of development, like really making progress with gross motor skills for a period of time, and you might see the language development just plateau just a bit, but then they hit some milestone with gross motor, and then the language takes off. And so it's a little, you just have to kind of look at the whole picture when you're assessing a child's development and look at the trajectory. That's really very, very important.
Gotcha. So you mentioned Piaget and Erikson, and I've got the usual bullet points of progress through childhood. So why don't we start there? Let's start with normal expected childhood development. Let's just talk about some of you mentioned milestones in cognitive development. So I will go to Piaget. From birth to about 2 years, Piaget talks about the development of the sensorimotor skills. The senses, motor meaning muscles and whatnot, where infants learn about the world through their senses and their motor actions. So can you flesh that out a little bit more for us? You've got a newborn up to about age 2. What type of sensorimotor developments would you want to see?
Yeah, there's so much going on. 0 to 2 is such a pivotal range, and there's so much development that occurs during those 2 years that can be formative and foundational for later development. And, as an infants, everything's brand new to them, right? So the whole world is new. And so they're taking in everything, and we want to allow them space to explore their environment, give them some of that positive feedback. And so infants are early on, as their visual skills are emerging, looking for parents' faces, particularly mothers' faces, and the time of breastfeeding. If a mother's breastfeeding is really important for infants, will often make eye contact with their mother during that time, and can be a really social, an important social milestone for infants. And infants are also exploring their environment tactily, so visually, but also tactily. So lots of grabbing of, infants will still have that reflex where everything you put in their hand's going to close early on. And as they get a little bit older, their grasp may change a little bit. Instead of a whole hand, it may be more just fingers, fingertips, and then finally more of like a pincer grasp to get things. And we like to see infants bringing moving objects from one hand to the other. So often when they're younger, they may just hold things in one hand, and that's very appropriate. They kind of shake it. That's why babies like rattles and things. And, they have that reflex. They're going to grab onto it and just move it, and then it's making a noise. That's giving them feedback. As they get a little older, they may start to transfer items from one hand to the other, kind of cross the midline. That's a really important milestone. Lots of things in those first 2 years. And then in our world now, and I know you had Dr. Beversdorf on for autism in episode 25, go check it out. One of the things we really look at is the development of joint attention, the development of social communication skills.
What is joint attention?
So when an infant, they may follow a parent's point or follow a parent's gaze to another object. So if mom is looking at something on the table and the infant looks at mom and sees mom's looking at that, the infant may look at whatever mom is looking at. Or the child may see something of interest to them across the room, and they want the parent or caregiver to see that same cool thing. And so there's a cookie over there, and they're like, boy, I'd really like that cookie. And they're looking at it, and then they're looking at their caregiver like, I want that.
Joint attention, I see.
Yeah. So they're trying to get your attention on the thing that they're looking at. And as kids get a little older, past a year or so, will start to point. So one is proto-declarative pointing. So they're pointing to point out something of interest. So they see a dog over there, so they might point to the dog, and they're saying, I declare this is really interesting. That's proto-declarative pointing.
Interesting.
And then proto-imperative pointing is pointing to request something. So I see a toy over there. I want that toy. That sort of things.
Yes. Oh, how cool. Yeah, I know this, but I didn't know what to call it. Right.
Yeah. So there's lots of different things that are occurring in those first 2 years. And then gross motor is obviously really important. And so we often will see infants sitting up independently. We like to see them sitting up independently and having some head control by about 6 months or so. And then they will, some infants will start crawling, but it's not really a developmental milestone, so it's normal if you just skip crawling. That's fine.
Go straight to walking.
Go straight to walking. So that's considered just fine. And usually around a year or so, infants will, sometimes a little before, will start to cruise, where they're kind of hanging on to objects and moving around the room.
Right.
And then from there, then they'll take some independent steps. And then, once they start doing that, it's kind of off to the races for parents.
So I've always heard that about 1 year is where you start to see the walking.
Mm-hmm.
When would you be concerned that it's taking too long? I assume getting up and walking earlier, there's no problem with that.
Usually not, though you do want to have an assessment of tone and make sure there's not increased tone or something like that if we're seeing some of those things early. But yeah, usually if we're not seeing infants walking by 15 months, we're starting to investigate a little bit. By 18 months, we're investigating a little bit more.
Okay.
And it really, again, depends on the whole picture. What are we seeing as far as as a child's tone? What are their other motor development skills?
That's their muscle tone.
Whether
they're rigid or they
Correct.
Have normal.
Right. Are they
motions.
really kind of floppy, hypotonic as we call it?
Okay.
Or are they really rigid, have hypertonia, or is their tone pretty normal? What do the reflexes look like? So those are some of the things that we're kind of looking at as we're assessing ambulation. But beyond 18 months, you start to get a little more worried if a child's not making significant progress towards independent walking.
How about vocalization and speaking? What would be a normal? Obviously, when a baby is born, we like it to cry.
Yeah.
The old-fashioned, and I remember when I was an OB resident, the older obstetricians, when they dictated in a delivery, said baby emitted a lusty cry. That was the term. These are screaming their heads off, and everybody liked that.
Yeah.
So a lusty cry was. Yeah. I'll never forget that. So that's a good thing. When you're born, apparently it clears out the lungs and gets the lungs going because they got to breathe air now instead of water. So what kind of development of vocalization and speaking would you see in that first year or two, Ben?
Yeah, so it usually starts early on with just like you said, we want to hear those infant cries, we want to hear vocalizations, and so it starts off with kind of babbling and some vowel sounds, the ahs and e's and things like that, and then you start to see some combination of vowel and consonant, and usually it's ma, 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 da, 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 those sorts of things that you might start to hear first.
When would that come?
Usually we like to see kind of non-specific by 9 months or so, some of those vocalizations, sometimes earlier, sometimes a little later. And shortly after they start to do some of those vocalizations, we will see them start to use mama more specifically. So first, it's kind of non-specific. They're just saying ma to everything, and there's just them kind of playing with noise. And then they start to realize, oh, Mom likes it when I say mama. Mom's
that
telling
might
me
be
to say,
mama, yeah.
Then mom likes it when I say mama. Mom's telling me to say mama. And then they start to make that kind of connection and use those words more specifically, or those sounds more specifically. And usually by a year of age, we start to see kids making those specific overtures to mom and dad, mama, dada, and start to add in some single words as well. And so, and if we're not seeing that progression, where we're not seeing the babbling to some of the non-specific sounds, the ma, 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 da, 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 then you start to investigate the child's hearing. You want to get a hearing evaluation, things like that, if you're not seeing that progression. And then certainly between a year and 2 years of age, you start to see those vocalizations, really just ramp up incredibly. And especially from a year to 3 years of age, it's just an explosion of language. That's usually the big thing that's going on in a child's development at that point in time, and it's so fun to see that progress. And if a child's struggling with some of those things, again, the hearing evaluation is really paramount. And then if beyond a year and a half, certainly up to 2 years of age, we're really struggling with language, we would get speech therapy involved to kind of help with some of those things.
So I have a question about languages. Is there a best time to start? Let's say you want to learn a different language in the home or something, or you're from a different country. Let's say you speak Spanish in the home.
Yeah.
And is there any time to not speak the second language, or speak them both at the same time, or 3 languages? Is there any recommendation or evidence for that?
Yeah, I'm really glad you brought this up, because this is one of those really common misconceptions around language. And it'll show up on boards and things like that, because
examinations.
Yeah, people still believe this, that if you're in a dual language household, that somehow limits a child's language development or thwarts a child's language development. And that's just absolutely not true. Kids are amazing. And if you are in a dual language household that speaks Spanish and English, or the child primarily speaks Spanish at home, but they go to a school and speak English, they're going to learn those languages just as well as they would have learned one language. The caveat is, when we're assessing developmental milestones, we kind of look at both languages together. So if we're expecting a child to have 50 words, and the parents are like, well, I think they've got 20 words or 25 words in English and maybe 25 words in Spanish, that counts. That's 50 words.
There you go.
And so the data on dual language households suggests it's not limiting to a child's development. and can be really rich. And so exposure to bilingual households even early on is can be really helpful and can enhance a child's development.
Yeah, not to be discouraged at all.
No. And another, while we're on misconceptions, another one we hear often as well, they have older siblings and the older siblings talk for them. And so that's why, Johnny is delayed in his language. And that really doesn't bear out either. And so if we're getting that sort of story from families, we will still investigate that child's language and look at hearing and have a speech and language assessment because that isn't sufficient to explain a child's delays.
Gotcha. Now, how about gaze and attention and eye contact? Can you tell me how does that develop in a little baby to a young child?
Yeah. So as I mentioned, when infants are really young, that breastfeeding time can be really important. They have difficulty early on accommodating and seeing items that are far away or sometimes too close. But the distance between them and the mother when they're breastfeeding, they can actually see the mother's face fairly well. As they get older, human gaze and eye contact with others is a really important, fundamental developmental milestone. And so that's something that parents can really help to encourage. And so when the child's making eye contact with them, giving that back with positive vocalizations or a smile. And we like to see as infants get a little older, having that social smile, usually between 3 and 6 months, you start to see that really emerge where early on they might smile, but sometimes it's just gas. But as they get a little older, into a few months old, you start to see a true social smile where it's someone smiling at them, they're reciprocating that smile, and that's really important. And we talked a little bit about other aspects of gaze, and so joint attention, and so sharing gaze on a object of interest across the room, but then just that gaze with parent or with other people in the child's life is also really important.
Is there a point where children start to recognize what is true or actual and then start pretending?
Yeah.
How does that develop?
Yeah, it's fun to see pretend play really emerge in some of those preschool years is typically when you'll start to see that emerge. And it is also a really important developmental milestone and using objects for not their intended purpose. So taking a block and pretending the block is a car, or pretending the block is a train, or pretending the block is food or something. That's creative play, and that sort of thing should be really encouraged. And sometimes, and well-meaning parents, we all do this. We buy our kids every plaything under the sun, and you have all the toys in the world, right? And it's like I have a representational object of everything, but sometimes the silliest thing is the best thing for a kid to play with. And it's the old adage, you buy a child this really cool toy and they instead play with the box that the toy came in. That's really healthy development, right? So the kid's like, well, forget the toy. I want this box because this box is now a UFO. This box is now my spaceship. It's my train, all of these things. And that's really, really fun and can be a really engaging part of a child's development where parents can be involved in this play, follow the child's lead instead of inserting our own thoughts and desires about what the box is. Let the child tell you what the box is and go with it. Just have fun with it and see where that goes. And that's the most fun to watch.
Now, touch. Most healthy humans like touch. Mm-hmm. And apparently, and I saw something on TV a few nights ago. Apparently, there is a rhythm. Apparently, there's a degree. If you have mothers and children, you just put them in one of your one-way mirror rooms and you watch to soothe the baby. Apparently, there's, takes 2 or 3 seconds per touch or something. What is it about touch and how does that develop in babies.
Yeah, that's I didn't know there was a defined, so that's news to me, a defined rhythm.
A rhythm apparently every 3 seconds.
Yeah, but I believe it because there are those people that are seemingly infant whisperers, and they just they must be in tune with that rhythm and can soothe any infant seemingly. And but it provides a level of comfort, protection, certainly when infants are young and need that. It can be a sign of approval. And so one thing we recommend for parents who might be struggling with a child's attention or behavior, even in the preschool years or the toddler years, it's gentle touch. If your child's engaging in something that you see as being a really positive thing, they're playing really well with their toys or playing really well with a sibling, just walking by and giving them a gentle touch on the shoulder is signifying, I see you, I approve of this. And it's a way of fostering confidence in the child, a way of providing approval without interrupting their play, without having to stop and say, oh, I really like what you're doing. You don't have to use any words. Just the touch itself has been shown to be really important in kind of developing some of those skills.
Now, is there a little variation? And some kids don't want to be touched, and that's normal, or maybe they're in a mood and they don't want to be touched. So is there normal variation? Yeah,
certainly. So, all of us, there are moments when it's like, I need my space, get out of my business. I need a minute to myself. And sometimes kids will have those moments as well. It's important for infants even to learn to self-soothe. And so, there may be moments where, it's okay to leave the child and let them cry for a minute as long as they're not in significant distress. And sometimes that's healthy. And then as kids get older, there's variation there. And so there may be moments when the kid does not want to be touched or want to be engaged by the caregiver. And there are those kids that really truly have some sensory sensitivities. And so they don't like, some kids don't like certain kinds of touch, may not like deep pressure, or really want deep pressure and not like light touch. There may be kids who don't like having their hair touched, their hair washed, like having their teeth brushed, things like that. And so those can be things that we see and associate with other neurodevelopmental conditions, but they can be normal if they're just kind of standalone sensory sensitivities and there's not other developmental concerns. It could just be part of that child's makeup. But it is something we watch and sometimes employ our occupational therapist to help with some of those things.
I've got all these questions. I didn't plan these, Pat.
Well, good, because I didn't plan anything either. So we're starting at the same point.
Music.
Yeah.
You hear about, infant, in the womb, in utero, hearing music and stuff. And can they really hear it? And is it making a difference? And you have these stereotypical lullabies. It seems like almost every culture has these. Like Mary Had a Little Lamb is the same song as the Starlight. Anyway, Twinkle Twinkle Little Star. Exactly, it's the same song, right? Yeah. When does musical appreciation develop, and when would kids start singing? Is there a milestone for that?
Well, not necessarily a milestone that we track, but as their language develops, that would be more common for them to start to perhaps sing along to songs and things like that. But even earlier, before their language develops, kids may recognize certain songs or find comfort in certain songs. And so kids develop associations, and those can be positive or negative associations. And often there may be certain songs that are associated with bath time or bedtime, and those can be really positive associations for kids. So through that mechanism, they develop that appreciation for music. And I think, there's music therapists that visit NICUs. There's music therapists that visit that work with some of our patients in a variety of settings. And I think there's a lot of benefit in that. It's certainly no harm. It's one of those interventions, not going to cause any harm.
Right.
It's going to be something that the child enjoys. And I think music is a really positive thing to have as part of a household with a developing child.
Another vexing problem is crying. Every infant cries.
Yes, yeah.
So that's normal.
It is normal, yeah.
The question is, how much is normal?
Mm-hmm.
When does it suggest a problem?
Mm-hmm.
Is it bloody colic? Is it what is it? Did you have any insight on crying? When is crying should suggest a problem? Because all parents are tuned, we've got buttons in us, crying, bad, try to fix it, right?
Mm-hmm.
So tell me something about crying.
And usually crying is for infants, it's a form of communication, so they don't have other verbal skills at that point when the crying is more predominant. Certainly crying persists beyond infanthood. But in infancy, crying is often a communicative strategy, if you want to call it that.
Sure.
And mothers and sometimes fathers, but usually mothers, they're more in tune with their infants, will be able to discern specific cries and be like, oh, that's a hungry cry, or that's a I need changing cry, or that's a I'm really tired cry, or I need to be held. And so crying is very normative. Now, if crying is persisting and it is not stopping despite a parent's best efforts, and you try feeding and maybe the child's not feeding well, or you try rocking and it's just nothing is going well, and this persists for an hour or 2 hours, certainly at least a call to the pediatrician is a good idea. Sometimes that can be a sign of some other physical issue, be it an infection or, like you said, colic, and just something that needs to be evaluated. And sometimes infants just cry, and you have to do the best you can. And that's where it's really helpful if you have access to other caregivers or other family members. It's really important for individual parents to be able to take a break from that, because that's where it can get really stressful for a parent.
Right.
If you're the one that's always responding to a lot of crying. And so it's important to have, it takes a village. Again, that's an old adage, but sometimes it really does. It takes a lot of people in order to help raise a child effectively.
So there's this explosion of verbal capacity, physical capacity up to around age 2, 3.
Mm-hmm.
What are the next important milestones? I see that PIJ was talking about from age 2 to 7. He called it pre-operational. What kind of further refining of development are you going to see from 2 to 7?
Yeah, there's lots of social development that occurs in 2 to 7, which makes sense. You think, preschool is happening usually for a lot of kids around age 3. They may be in pre-K, and when they're like 2 to 3, they're kind of playing. We call it parallel play. They're playing next to their friends. So they might be, I'm over here, I'm building with blocks. I'm over here, I'm playing with cars. From the outside observer, we may look like we're playing with each other because we're playing next to each other, but we're really not interacting. We're not cooperating, sharing, things like that. And so parallel play is a very normal part of development. But beyond 2 and 3, you start to see more interaction in the play, and that's a lot of fun to watch. And that's where some of those life skills, like sharing,
right,
which is hard even into adulthood sometimes.
Sometimes
that's hard. Taking turns, and when you think of all the things that have to go into cooperative play, it's a lot. There's emotional regulation. There has to be some level of understanding what the other person needs and wants. There has to be a little bit of compromise. Well, I want to move the car this way. Well, I want to move the car that way. We have to, in order for us to play together, we have to arrive at some conclusion.
That's right. And report cards, it used to be plays well with others.
Yeah.
That was a criterion of grading.
Yeah. In kindergarten and preschool and into kindergarten, those are some of the foundational things that teachers are trying to help promote. So I think in those ages, that's what I really see a lot of is a lot of social development, learning to navigate in different groups, learning to navigate relationships with other kids, learning to share, learning some emotional regulation. Some of those skills are really important in that time frame.
Now, how do you think kids learn that kind of stuff? Is it like if you're in a good functional household where do they just observe it, or do they learn this by osmosis, or is it trial and error? Where all of the above?
Yeah, child development, I think, is really multifactorial. There's so many factors involved. There's genetics, the inherited genetics from mom, the inherited genetics and tendencies from dad. There's the child's temperament, which sometimes mirrors those genetics and sometimes not. And sometimes a child just has a more difficult temperament. Household environment definitely plays a role. But I will say, you can have a household that is the most functional household with really great role models in the home and siblings who are providing great role models. And you might still have a kid who has lots of challenges with emotional regulation because it is multifactorial. And you have kids who have really difficult households and challenging childhood situations who develop wonderful emotional regulation skills. So it's not all environment, but environment is important. But there's so many factors that go into it, including a child's temperament, their genetics, and some of those formative, environmental factors as well.
Personality.
Yeah.
I've heard it said a child's personality is pretty much formed by age 5. Then I've heard people say probably mostly there by age 3. Mm-hmm. Tell me about personality. When does it form? And when can you say, well, that's just going to be their personality? At what age?
Yeah, I don't know if there's a specific age you can say, but you certainly can see a child's temperament early on, certainly into toddlerhood, pre-K. Some of the foundational aspects of their temperament become more clear. And so you have those kids that are very socially gregarious. They're very outgoing. And that's, when you see that early on, it's likely that's going to be part of their makeup as they progress through childhood and beyond. And there are those kids that temperamentally are a little more shy, a little more reserved, a little more slow to warm up. And if that's their temperament early on, often it'll continue to follow that same course. But throughout a child's life, there are so many factors that can impact how they react to the world. And so though their temperament may be hardwired early on, there are lots of situations that may impact that one way or another.
And I assume traumas are something that could really alter the trajectory if there's a big change in their environment.
Yeah, that's one of the factors I was thinking of as well. Trauma can definitely have a significant impact on what the child looks like, especially for me as a physician. If I'm seeing a child, I may have an initial impression of, okay, this is what this child is like. But on further digging, sometimes you find there was a traumatic experience and things weren't always this way, and what we're seeing is a little different than what the child's developmental trajectory had been. So, yeah, it's important to take into consideration all of those factors that can impact the child.
Okay. Let's just go a little bit later here. Piaget calls it the concrete operational years. Calls it around age 7 to 11, when his feeling was thinking becomes more logical and organized, and that concrete concepts like conservation. I know if you have something behind here and you hide it and they can conceive that, well, it's hidden there, but it's still there. Mm-hmm. concrete thinking. Tell me a little bit about concrete thinking and those types of developments.
Yeah, so that age group, 7 to 11, kids are really starting to understand the larger world around them a little bit more. And before that, it's a little bit more, their world is a smaller orbit. But between 7 and 11, they're in school, they're exposed to a lot more things. Concepts like death, become a little bit more. Kids in that age group start to understand that a little bit more. And it's not uncommon, not to focus on a morbid topic, but it's not uncommon for kids who are like 6 and 7 to talk more about death for a period of time because they're just starting to understand the concept.
And they have pets.
And the finality of death. And so sometimes parents will be really concerned. They're talking about death a lot.
And the goldfish die,
Yeah, and that can be concerning, but it can also be part of normal development. They're starting to understand, this is what death is. That death is final. And it can take a lot of some processing for kids to kind of figure that out. But yeah, those are also really formative years, and yeah, I kind of like that description of kind of organizing thoughts and again applying that to the natural world around them, kind of understanding rules a little bit more, understanding if someone's not following the rules and why it's important to follow the rules and things like that start to be more important for kids in that age group.
Final question about normal development, because now that we've got an idea what normal is, we're going to go back and kind of see how to identify red flags of abnormal development. Fine motor skills. There's a stereotypical type of mother that's teaching their kid to play violin real early, right?
Sure.
When does that type of fine motor skill and coordination come to be?
Yeah. Well, the for the fine motor involved in learning an instrument and things like that, it's pretty, you'll hear stories of kids doing it before age 4, but usually...
I don't know if Mozart was playing it by age. Maybe Hunter can look that up. When did Mozart start playing violin, supposedly?
Yeah. Someone like Mozart was, probably doing it very early, but most kids aren't going to be learning those types of skills until 4, and even really 6 and beyond is going to be more normative. But there's definitely, we kind of touched on it a little bit, there's definitely a trajectory for fine motor development, and I think about some of the grasping. So again, when kids are really young, they're grasping objects with their whole fist. And then as they get a little bit older, we start to see some refinement in that, and then they start to grasp things a little bit more with the first 3 fingers and thumb, perhaps. And then when they get older, it's just the fingertips and so forth. At 6. So Mozart was playing a violin at 6. Okay, very good. So yeah, hard to put your kids up against Mozart. So yeah, maybe wait till 6. We do have some patients who will start to dabble on the piano and maybe take some lessons around 4, but more common it's around the age of reading when kids can get the concept of reading music and things like that.
Like 6, 7, 8.
6, yeah.
Something like that. I remember when I was a medical student in pediatrics, they test the kids with raisins.
Yeah.
Raisins. It's safe, it's soft, you can eat it, you can drop it on the floor. Picking up a raisin was the test of...
we use Cheerios now or like the Puffs or something like that, something that's really small that... Yeah, you don't want to use like some of the kits will have like beads in them and things, and we're like, okay, well, let's get rid of the bead and put something that's edible because kids are quick; they'll pick it up and
it's down the hatch.
So you don't want to be fishing those non-edibles out.
So now, Ben, you've given me a pretty good idea of normal development. So let's go back. Woman has a baby. Something's not quite right. Maybe it's not crying much. Maybe it's not latching very well. Now, obviously, there's trouble latching and whatnot. But what are some of the early signs that maybe there's a developmental problem? Now, this is a big question.
It is.
All right, I just asked you. There's 100,000 different things that might go wrong.
Yeah.
But let's start right off from those first few weeks.
Yeah, yeah.
Baby's not latching.
Yeah.
I don't want to come up with all the bad things that can happen. Maybe let's start with crying. Mm-hmm. Baby's not crying. Mm-hmm. Not crying. Is that something to be alarmed about? Is there too little crying that would make you concerned?
Well, so an infant's usually going to make some noises and some cries, but if we're not seeing the cries evolve into kind of the normal sound development, not creating some of those vowel sounds, not doing some of the babbling that we usually like to see in the first few months, not organizing some of those vocalizations, then that's a reason to bring that up to the general pediatrician.
What does that mean? Explain to a lay person. What do you mean by that? How would the cry? Would it be more just shrill?
Well, I don't know. There may be characteristics about the cry itself. We have a researcher who studies infant cries.
That's why you're here. You're the expert. The experts.
And looks at how infant cries may predict subsequent diagnosis of neurodevelopmental conditions. And they record infant cries and analyze them using fancy software and are able to identify some characteristics of cries that might be associated with neurodevelopmental conditions versus cries of infants who have typical development.
So you might be able to recognize this because you hear these things.
Yeah.
Well, is there any way to better describe it for a lay person?
Not necessarily. They use fancy analytical software to look at these recorded cries. But if an infant's not developing the normal vocalization, so kind of apart from the cries, not making other babbling sounds and things like that, that would be a red flag. And general pediatricians nowadays are assessing a child's development at every well-child visit, and there's a lot of well-child visits. And so they're looking at these milestones at every well-child visit, and if a child's not hitting them, they should be recognizing that based off their screening. And if they're not, parents should feel empowered to bring that up. And I always tell trainees who work with me, if a mother brings something up to you more than once and says it's a concern, you better darn listen, because more often than not, they are right. And so if a mother says this is a concern, if they say it to you more than once, then you better investigate a little bit.
That's a good rule of thumb. Now, is there anything about desire to eat? I'd mentioned latching, and that's maybe a separate issue. Is there anything that you can glean from a child not wanting to eat?
So there can be lots of issues associated with feeding issues in infancy. And so you talked about latching. So sometimes that can be a sign of lots of things. Sometimes that could be a sign of poor tone. We kind of mentioned muscle tone. That can be associated with some infant feeding issues early on. Sometimes infants may tire with feeding, and that can be a sign of other medical issues such as cardiac issues or others, or other genetic concerns. And as far as other feeding concerns, so if an infant is having difficulty handling a bolus of food, swallowing it comfortably, or maybe choking on foods, that can be a sign of some feeding and swallowing issues. And so, lots of investigations that can be done to help look at that more specifically.
Gotcha. Now, I had mentioned touch, and most babies like to be held. Now, the papoose. Native Americans would swaddle it. Baby's always been swaddled and wrapped. It was explained to me it kind of mimics being in the womb where it's all kind of tight and maybe that's cozy.
Yeah.
Is there any reason to do that or not do that? Is that a normal thing to do and comfort a child? And should the child feel comforted by that kind of treatment?
Yeah, so there's evidence. There's lots of different cultural differences in how infants are handled by their mother. And yeah, definitely in some cultures, the infant is with the mother all the time. They may be kind of wrapped to their chest or to their back. And it's worked well in those cultures. And American culture hasn't had that as part of it. And part of that's social context. Our mothers might be in a workplace or in another place where having an infant just strapped to you during the day is not really feasible. And so there are cultural differences that play a role in that. But there is something to be to swaddling. So, in NICUs, infants are swaddled.
That's neonatal intensive care?
Correct. And, in hospitals, if babies are in the hospital, they're swaddled. And at home, lots of mothers and caregivers will swaddle their infants when they're in the crib or swaddle them while they're being held. And there's good reason to do that. It provides warmth and comfort for the child. And then as they get older, the swaddling is a little bit more of a barrier because kids want to explore with their hands. And so it becomes less important. So, but early on, that touch is really important.
Now, is there a point at which if an infant, small child does not like being touched, that should raise a red flag? Well, this is maybe you go to hug your kid and doesn't want it, doesn't like it, doesn't provide comfort. Is there a point at which you say, well, gee, this is an abnormal response?
Mm-hmm. Well, one parallel I can think of is the stranger, fear of strangers or stranger anxiety. And often we see that really start to emerge between 9 and 12 months or so. And usually, so if a child goes to a stranger, a typically developing child during that time frame may not like it and may cry and kind of put up a fuss. And then when the child's transferred back to their parent, the parent kind of hugs them, they soothe, and they're like, okay, this is better. Sometimes that can be a little bit of a red flag if a child does not show that stranger anxiety, and then going back to caregiver isn't comforting or soothing. We see a lot of patients with autism, and when we're taking developmental history, sometimes parents will say, yeah, they never really, they were okay if I hugged them or if I held them, but they never really sought it out. Or as they got older, they seemed to not like it and they would kind of push me away when I would try to give a hug. So sometimes that's part of the developmental history we get. That in isolation is not enough to say, oh, my child has autism or have may not be a huge red flag in isolation, but in context with other developmental concerns, it could be something to take note of.
So a parent is talking to a child, trying to baby talk, whatever it might be. Is there a point at which the infant may just ignore you and not hear it? And that also raises some concern. Maybe there's not as much attention or interaction or appreciation of that might be, seems very subtle, but maybe a parent would pick up on that.
Yeah, and it's harder for parents, first-time parents, to pick up on some of these things. Sometimes it's a little easier for parents who may have had other children who had followed a more or less typical developmental course to pick up on differences. But some of that in infancy up through a year of age and certainly beyond, as language is really developing, even before an infant has verbal words, before they're saying words that are meaningful, they're still making vocalizations and there's still that interchange, still a volley. So we really encourage parents to do that with their child, kind of play with the noises. So if a child's making a noise, repeat that noise back to them, maybe add a little variation, see if they repeat back to you. And that's a back and forth. And a typically developing child will often kind of follow that volley. There might be some laughing, some eye contact, and repetition and kind of volleying those sounds back and forth. And that's a really important thing for parents to try and do. And if a child's, we all have good days and bad days, or maybe days when a child's like, I don't want to do this right now. That's fine. I'm tired. But if they're consistently not really engaging in that back and forth, that can certainly be something to bring up to the pediatrician and could be a red flag.
Yeah, and I've heard it called passivity, when there's really low activity and almost a withdrawn, I don't even know what to call it. Is it?
Yeah.
Affect.
Yeah, withdrawn. Sometimes we do say, parents will, on kind of retrospective examination of their child's developmental history, will say, yeah, they just seemed a little more withdrawn. They didn't seem so as into me as maybe the other kids, or didn't seem so interested in other people in the room. Seemed more, a characteristic we often look for is that kids that are more object-focused than person-focused. And so it's really most infants are gonna be much more person focused. They're going to be engaged with facial expressions and looking to see what the person's doing, looking to see what noises they're making, what they're looking at. But if a child's much more occupied with the toy and parts of the toy and is kind of ignoring the person, that would be. So those kids that are more object focused versus person focused can be a red flag.
Interesting. Now, Ben, it would take me however many years of training to learn what you, and all the years of practice that you've had under your belt. As I start to wrap this up, I'm looking for some general advice I'd like to give people. And what I've heard from you already is probably trust your instincts. If something just seems wrong, maybe it is. I've heard you mention well baby visits or well child visits. It sounds to me like you're a big advocate of them.
Yeah.
What would be a normal well child schedule?
Yeah. Boy, I'm not in general pediatrics anymore, but usually they want to see the infant shortly after, within a few weeks of discharge from the hospital.
From birth, so a month or so old.
Yeah, and sometimes even earlier than that. And then a month, 2 months, 3 months. So there's a 24. I'm getting into the years. Yeah, 1 month, 2 month, 4 months, 6 month, and then a 9 month, 12 month, usually a 15 month, and then they start to space out. And some of this is driven by vaccine schedule. Some of it's driven by developmental monitoring, and sometimes there are visits that'll be inserted in there. So if a pediatrician has concerns, they might say, okay, come back and see me in a month or two, which might be earlier. But it's really important to go to those well child visits because it's an opportunity for an expert to see what your child's doing and make sure that things are progressing okay. But also as for you as a parent to ask questions. And you don't want to turn to Dr. Google or these days Dr. ChatGPT for everything. And so it's really important to have those engagements with a provider who knows your child, knows your family, and can provide good advice.
So you're an advocate for well child visits?
Definitely an advocate for well child visits, yeah.
Gotcha. So if there's any question, bring it up with your pediatrician. Hopefully you have one. And they would know to call you in or someone at your staff for further expertise if they detect a problem.
Yeah, and for the infants or for the children that come to us, so we at our center, we do have a NICU follow-up clinic, so the neonatal intensive care unit follow-up clinic, so those babies that were discharged from that. We do see some infants in other clinics as well. Most of the patients that come to us for developmental concerns, those tend to emerge 12 months, 15 months. A lot of times it's the social communication deficits, the language delays, and things like that that we're getting patients referred to us.
So a little after a year, it's so far off the curve and so abnormal and persistent, and not just a personality or what's called a quirk of this little person, but
you start to see more of those patterns emerge over time
between years 1 and 2. Fascinating. Well, as we wrap this up, Ben, are there any take-home messages you'd like to share with our audience, or any little pearls I've not covered that you'd like to share?
I think when I think about child development, one thing I really think is super important is just encouraging play. And it sounds simple and silly, perhaps, but we're such a busy, scheduled society, and sometimes we forget to just have time to just do nothing and play and just interact with the world. And kids do that better than anybody, but we need to give them the space and the time to do that. And as a caregiver, be there with them. Enjoy those moments, because that can be refreshing for you as a caregiver too. To just remember, like, it's fun to not have an agenda and just like see what happens. All right, we have some blocks and we've got this book over here, and let's see what happens. And try to see the world from the child's perspective a little bit. And I think that's one of the most important things. Just encourage a child's creative play, whatever that looks like for that child at that developmental level, and join them in that process and encourage that, whatever that looks like.
Well, thank you so much, Ben. I've learned an awful lot. Once again, you are the associate professor of pediatrics, and you're the director of medical services at the Thompson Center here at MU. And the Thompson Center was started 20 years ago in 2005.
Yeah, we're celebrating some important milestones. This year has been a huge deal for us, and over the next few months, we're actually moving into a new building down by the South Providence Medical Building on the MU campus on South Providence, and 75,000 square foot building. They're going to be done with major construction by the end of this month, and then the hospital team moves in and starts moving in our furniture and things. So we're moving from we have a nice facility over on Portland Street and Keene Street now, but we're going to be moving on to some amazing things at our new center. We're really looking forward to it. It's an exciting time to be at the Thompson Center, exciting time to be at MU because of the growth in our center.
Fantastic. I look forward to watching you grow. Once again, Ben, thank you so much for your time.
It's a pleasure.
Really appreciate what you do for our community.
It was a pleasure. Thank you so much, Dr. Gil.